Welcome to the deep dive. Today we're going deep on ICD-10-CM. You know, that medical coding system that everyone loves.
Well, maybe not everyone loves, but they definitely need it. It's the backbone of healthcare in the U.S.
You've sent us a mountain of info on this, and we're going to break it all down.
From those crazy conventions to the guidelines.
Yeah, those general coding guidelines and the chapter-specific ones.
By the end of this, you'll be an ICD-10-CM whiz.
So I'm looking at all this stuff, and honestly, it's a little intimidating. I mean, all these abbreviations, punctuation marks.
Yeah, it's like its own language.
Exactly. So let's start with the basics. Those conventions are like the building blocks of this whole system.
I like that analogy. They're the foundation for understanding everything else.
Perfect. So first up, we've got abbreviations. Like I'm seeing NOS everywhere. What's the deal with that?
Oh, yeah. NOS. That stands for not otherwise specified. You'll see it when the medical record doesn't give you enough detail for a more specific code.
So it's kind of like a placeholder when the doc's being a little vague.
Pretty much. Like you might see pneumonia and us if the documentation doesn't say what kind of pneumonia it is.
Okay, so it's all about that level of detail.
Yeah.
Now, what about all these punctuation marks? I'm seeing parentheses, brackets, colons. It's like a code within a code.
It kind of is. Each punctuation mark has its own special meaning.
Hit me with it.
Okay, so parentheses, those enclose non-essential modifiers.
Non-essential meaning.
Meaning they're helpful but not crucial to the code's meaning. They just add a little extra detail.
Like a little bonus info.
Exactly. So imagine you see fracture of femur closed. The closed part is in parentheses because it's extra info.
But the main point is still the fracture.
Right. Now, brackets are a little different. Those usually show up around manifestation codes.
We'll get to those later, I'm sure.
We will. And then there are colons. Those tell you to look for more info in the tabular list.
So it's like a little arrow pointing you in the right direction.
Exactly.
Yeah.
Punctuation is your friend in ICD-10-CM.
Okay, I'm starting to see that. Now, this next one always trips me up. The word and. I mean, is it really just and, or is there some coding trickery going on?
Oh, there's definitely some trickery in the alphabetic index. And co can actually mean and/or.
Wait. So if I see injury to muscle and tendon, it could mean a muscle injury or a tendon injury or both.
You got it. Don't let that little word fool ya.
Sneaky. Now on to another tricky duo, other and unspecified. They sound so similar, but I bet there's a big difference.
You bet there is. Other is for when you have more info than a general code allows.
But there's no perfect code for the situation.
Right. It's like saying, well, it's kind of like this, but not exactly.
So you're stuck in coding limbo.
In a way. Now, unspecified is different. That's for when the documentation just isn't specific enough. You're literally missing information.
So it's not that there isn't a code, it's that you can't choose a more specific one.
Exactly. Other means you have extra details. Unspecified means you're missing details.
Got it. Okay, let's move on to those includes notes that pop up in the tabular list.
Oh, those are great. Think of them like little helpful hints from the coding gods.
I'll take all the help I can get.
They clarify the scope of a code category. They're like saying, hey, this code covers all these things.
They're making sure you're not missing anything.
Exactly. Now, in the alphabetic index, you've got inclusion terms.
Are those just synonyms for the main terms?
Nope. They actually expand the meaning of the main term. They add specific conditions or scenarios that are included under that code.
So they're broadening the scope of the code.
Precisely. Now let's talk about excludes notes. These are like the warning signs of ICD-10-CM.
Oh, I'm getting nervous.
Don't worry. They're here to help. They tell you what a code does not cover.
So you don't make any coding blunders.
Right. And just to make things interesting, there are two types. Excludes 1 and excludes 2.
Okay, lay it on me. What's the difference?
Excludes 1 notes are non-negotiable. They mean you absolutely cannot code these things together ever.
So it's like a coding deal breaker.
Exactly. Like if a patient has both type 1 A and D, type 2 diabetes, you can't code both. You got to pick one.
Okay, so that's pretty clear cut. Now what about excludes 2?
Those are a little more flexible. They mean that the excluded condition isn't part of the main code. But UT, a patient could have both.
So it's more like a heads up that you might need another code.
Right, like you might see an excludes 2 note saying hypertension next to a code for heart failure. That doesn't mean the patient can't have hypertension. It just means you need a separate code for it if they do.
Okay, I see. So excludes 1 is a hard no, and excludes 2 is more like proceed with caution.
Perfect analogy. Now on to a convention that sounds a little intimidating. The etiology manifestation dance.
Oh boy, this sounds complicated.
It's not as bad as it sounds. It's really just about understanding the relationship between a cause and its effect.
Like a domino effect. One thing leads to another.
Exactly. So in coding terms, the etiology is the cause and the manifestation is the effect.
Okay, so give me a real-world example.
Sure. Let's say a patient has cirrhosis of the liver because of hepatitis C. The hepatitis C is the etiology and the cirrhosis is the manifestation.
So we're coding both the underlying cause and the resulting problem.
You got it. And the key here is to sequence them correctly. Etiology code first, followed by the manifestation code.
Order matters. It's not just what you code, it's how you code it.
You got it. That's the essence of the etiology manifestation dance.
Okay, I think I've got the steps down. Now that we've covered those basic conventions, those building blocks of ICD-10-CM, let's move on to the general coding guidelines. These are like the rules of the road for coding, right?
Exactly. They're the overarching principles that guide us through the whole process.
Okay, so let's lay down the law. What's the first guideline we need to know?
The first one is all about finding the right code, navigating that maze of medical terminology and code choices.
That's tricky.
It can be, but luckily it's a two-step process. You start in the alphabetic index, you look up the main term, the condition or symptom you're trying to code. That gives you a starting point.
Okay, so that's like using a map to find our general location.
Exactly. Then we head over to the tabular list to make sure we're choosing the most specific code possible. And that's where those includes notes, excludes notes, and other conventions come in handy. They help us refine our code selection.
So it's like zooming in on the map to find the exact address.
Precisely. And don't forget to check those seventh characters. They can add a whole other level of detail.
Yes, those little digits that pack a big punch. Now let's talk about a guideline that seems pretty straightforward but can be tricky in practice. Coding for signs and symptoms. When is it okay to use a symptom code as the primary diagnosis?
That's a great question. The general rule is you can use a symptom code when you don't have a confirmed diagnosis. It's like saying, we know something's wrong, but we need more info to figure out exactly what it is.
So it's a placeholder until the mystery is solved?
Exactly. But sometimes a symptom code IS the primary diagnosis.
Like when?
Well, imagine a patient comes in with severe abdominal pain, but after doing all sorts of tests, the doctor still can't figure out the cause. In that case, the abdominal pain code would be the primary diagnosis.
Because that's the reason for the encounter, even though the underlying cause is still a mystery.
Exactly. It's all about coding what you know a W, even if you don't have all the answers yet.
Okay, that makes sense. Now, this next guideline is about conditions that are an integral part of a disease process. What does that even mean in coding terms?
It means that certain signs and symptoms are so closely linked to a specific disease that you don't code them separately.
Unless the guidelines specifically tell you to?
Right. It's like a package deal. Those symptoms are just part and parcel of the main condition.
So for something like the flu, you wouldn't code the fever, cough, and sore throat separately. They're all part of that flu package.
Exactly. It's about understanding what's bundled into a diagnosis.
Got it. Now, on the flip side, what about conditions that are not an integral part of the disease process? When do we code those separately?
We code those separately when they're clinically significant and affect the patient's care, even if they're not directly related to the main diagnosis.
So like a patient with pneumonia who also has diabetes.
Exactly. The diabetes isn't caused by the pneumonia, but it can definitely affect the patient's treatment, so it needs its own code.
Okay, so we're painting a complete picture of the patient's health status. Now, this next guideline is about using multiple codes for a single condition. When would we need more than one code to describe a single problem?
We use multiple codes when a single code just can't capture the complexity of the situation. Remember that etiology manifestation dance we talked about? That often requires two codes, one for the cause and one for the effect.
Right, like coding both the hepatitis C and the resulting cirrhosis.
Exactly. And sometimes you need multiple codes to specify different aspects of a condition, like the location, the severity, or the presence of complications. Those use additional code notes in the tabular list are your best friend in those situations.
They're like little Cody breadcrumbs leading us to the right codes.
Perfect analogy. Now let's talk about sequelae, those late effects that linger after an injury or illness.
It's like a shadow of a past event.
Exactly.
Right.
Like a limp from an old fracture or shortness of breath after a bad case of pneumonia.
And coding sequelae usually involves two codes.
Right. First, you code the nature of the sequela, like the limp or the breathing problems. Then you add a code to specify the cause, like the fracture, the pneumonia.
So it's about connecting those dots between the past and the present.
Precisely. Now, what about those times when we're dealing with conditions that haven't actually happened yet? Those impending or threatened conditions.
How do you code for something that's a possibility but not a certainty?
It all comes down to what the documentation says. If the condition actually happened, then you code it as a confirmed diagnosis. But if it didn't happen, then you need to check the alphabetic index to see if there's a specific code for impending or threatened, whatever the condition is. If so, you use that code.
So it's like a conditional code. Depends on whether the threat became a reality.
Exactly. And if there's no specific code for the impending condition, then you code the underlying condition that's putting the patient at risk.
Okay, so we're capturing that potential for a problem even if it doesn't materialize. Now, this last general guideline is about those times when we're looking at documentation from other clinicians besides the patient's main doctor. Can we use those notes for coding?
That's a tricky one. It's really important to remember that the patient's provider is ultimately responsible for the diagnosis, but other clinicians often provide valuable information that can support the coding process.
So it's like a team effort.
In a way, like a nurse might document the stage of a pressure ulcer, or a dietitian might record the patient's BMI.
So we're using all the available information to get a complete picture.
Exactly. But there are specific guidelines about what info can and can't be coded based on documentation from other clinicians. You gotta know the rules.
No coding free-for-all.
Okay.
I think we've laid a solid foundation with those general coding guidelines.
Agreed. Those guidelines are our compass. They guide us through the crazy world of ICD-10-CM.
And now we're ready to dive into the chapter-specific guidelines, starting with Chapter 1, Certain Infectious and Parasitic Diseases.
Chapter 1 is a big one. Lots of interesting stuff to unpack.
I'm ready. Let's tackle those infectious agents.
Let's jump into Chapter 2, Neoplasms.
Neoplasms, that's a fancy word for tumors, right?
Yep. Benign and malignant.
Okay, so we're talking cancer coding.
Exactly. And this chapter can be tricky. There are so many nuances.
Like what?
Well, one of the trickiest things is understanding how the sequencing of codes can change depending on the treatment focus.
Treatment focus?
Yeah, like let's say a patient has a primary cancer that's spread to another part of the body.
Metastasis.
Exactly. Now, if they're being treated for the primary cancer, then that code comes first, followed by the code for the secondary site.
So it's like saying, here's the source and here's where it's spread.
Exactly. But here's the catch. If the treatment focus shifts to that secondary site, then the secondary neoplasm code actually comes first.
Even though the primary cancer is still there?
Yep. It's all about what's being actively treated.
Okay, so we're not just coding the presence of the tumor, we're coding the treatment strategy.
Yeah, exactly. It's about capturing the clinical intent. Now, what about those complications that can arise from cancer or its treatment?
Like anemia or infections.
Exactly. We need to code those two to paint a complete picture.
Guess how does that work?
Well, let's say a patient is admitted for anemia that's directly related to their cancer. In that case, the malignancy code comes first, followed by the anemia code.
So we're showing how the cancer is impacting other systems in the body.
Right. But if the anemia is a side effect of chemo, then the anemia code comes first, because that's the immediate reason for the encounter.
Got it. So the immediate problem takes priority, even if it's ultimately linked to the cancer.
Exactly. Now, let's say a patient has a primary malignancy that's been surgically removed, and there's no evidence of it left.
So the cancer is gone, but the history is still relevant.
Right. That's when we use a code from category Z85, Personal History of Malignant Neoplasm.
So it's like a been there, done that code.
Kinda. But what if the cancer had spread before it was removed?
Good question. Does that change things?
It does. If there's any mention of spread, then we code that as a secondary malignant neoplasm. And get this, that secondary site code might actually become the principal diagnosis.
Wow. So even though the primary cancer is gone, it can still influence the coding.
Yep. Now let's talk about chemotherapy, immunotherapy, and radiation therapy.
Those are the big guns in cancer treatment.
They are. And they have their own special coding rules.
Okay, break it down for me.
Well, if a patient has surgery to remove a tumor and then gets chemo or radiation during the same hospital stay, the neoplasm code is still the primary diagnosis.
So the surgery is the main event and the other treatments are just supporting players.
Exactly. But if the admission is specifically for chemoimmunotherapy or radiation, then things change a bit.
How so?
In those cases, the Z codes for those therapies become the principal diagnosis.
So the focus shifts and the coding follows suit.
You got it. So if someone is admitted for chemo, you'd use Z51.11 encounter for anti-neoplastic chemotherapy as the primary code, followed by the cancer code.
Okay, that makes sense. Now, what about those times when a patient has complications from chemo, immunotherapy, or radiation?
If the complication is the reason for the encounter, then it becomes the principal diagnosis, followed by the code for the therapy and the cancer code.
So the immediate problem takes priority even if it's linked to those ongoing cancer treatments.
Exactly. And there are a bunch of other scenarios and guidelines for neoplasm coding, like how to code for staging, how to differentiate between current and personal history of malignancy, and how to sequence codes when there are multiple tumors present. But we can save those details for another deep dive.
Sounds good. I think we've covered the basics of Chapter 2. Let's move on to Chapter 5, Mental, Behavioral, and Neurodevelopmental Disorders.
The complexities of the mind. This chapter is all about those mental health diagnoses.
Okay, bring on the psych codes. What are some key guidelines we need to know?
Well, one tricky area is differentiating between pain that's solely due to psychological factors and pain that has both a physical and psychological component.
So, like, is it all in their head or is there a real physical problem too?
Exactly. And there are specific codes for each scenario.
Okay, so give me an example.
Sure. Let's say a patient has chronic pain that's mostly caused by anxiety. We would use code F45.41 for that. But if the pain has both a physical and psychological component, like chronic back pain that's made worse by stress, then we'd use a different code, F45.42, along with a code from category G89 pain, not elsewhere classified, to specify the type of pain.
So we're either coding the pain as purely psychological or acknowledging that mind-body connection.
Precisely. Now, there's a whole section on coding substance use disorders in this chapter, but we can delve into those details another time.
That sounds good. I'm ready to move on to Chapter 6, Diseases of the Nervous System.
Chapter 6 covers a wide range of neurological conditions, from headaches to strokes to Parkinson's disease.
Okay, bring on the brain codes.
Well,
what are some key guidelines we need to know?
One of the biggest challenges in this chapter is coding for pain. It seems like pain is a factor in almost every neurological condition.
Yeah, pain is a tricky beast. So how do we tackle it in Chapter 6?
Well, one of the key things to remember is that we can use a code from category G89 pain, not elsewhere classified as the principal diagnosis in certain situations.
Like when?
Like if the encounter is specifically for pain control, so if a patient with a herniated disc comes in for a steroid injection to manage their back pain, the pain code would be the primary diagnosis.
Even though the herniated disc is the underlying cause.
Exactly. Because the focus of the encounter is pain management, and the same principle applies to those cases where a patient is admitted for the insertion of a neurostimulator for pain control.
Those are pretty amazing devices.
They are. And in those cases, the pain code is the primary driver because the whole purpose of the procedure is to manage that pain.
Okay, that makes sense. Now, do we ever use those G89 codes along with other more specific pain codes?
We do. It's all about providing a complete picture. So we might use G89.11. Acute pain due to trauma, along with M54.2 cervicalgia, to specify that the pain is in the neck.
So we're adding that extra layer of detail.
Exactly. And the sequencing of those codes depends on, you guessed it, the reason for the encounter.
If pain is the main focus, then the G89 code comes first.
Right. But if they're coming in for treatment of the underlying condition, then that code takes precedence.
Got it. Now, what about post-operative pain? Is that always coded with the G89 code?
Not always. It depends on whether the pain is just general post-op discomfort or if it's related to a complication.
So like pain from a surgical incision versus pain from a wound infection.
Exactly. If it's just general post-op pain, then a G89 code is appropriate. But if the pain is due to a complication, then we would code the complication first.
Okay, so we're distinguishing between those different types of pain.
Right. Now, there are also specific guidelines for coding chronic pain syndromes, like central pain syndrome and chronic pain syndrome, but we can save those details for another deep dive.
Sounds good. Let's move on to Chapter 9, Diseases of the Circulatory System. Always a busy chapter.
It is. This chapter covers a wide range of conditions, from hypertension to heart attacks to strokes.
Okay, bring on the heart codes. What are some key guidelines we need to know?
Well, let's start with hypertension. It's one of the most common circulatory system problems, and it can manifest in so many different ways.
So we're talking about high blood pressure.
Yep. And the key is to accurately differentiate between the various types of hypertension. We have benign hypertension, malignant hypertension, unspecified hypertension, and even secondary hypertension, which means it's caused by another underlying condition.
Okay, so lots of nuances.
Yeah.
And I'm guessing the sequencing of those codes can get tricky?
It can, but the general rule is to sequence the underlying cause first, followed by the code for secondary hypertension. So if someone has hypertension due to kidney disease, we would code the kidney disease first and then the hypertension code.
Got it. We're showing that cause and effect relationship. Now, what about when hypertension starts affecting the heart itself?
That's called hypertensive heart disease. And if the patient has heart failure due to hypertension, We would use a code from category I11, hypertensive heart disease, to specify the type of heart failure.
Okay, so we're capturing both the hypertension and its impact on the heart.
Exactly. Now, if the patient has both hypertensive heart disease and chronic kidney disease, we have a handy combination code we can use I13.
Combination codes always making life easier.
They do. But don't forget, I13 doesn't tell us the stage of the kidney disease. So we still need to add a code from category N18 chronic kidney disease to specify that.
Right, we capture all the details.
Exactly. Now, let's say the patient also has acute renal failure on top of everything else.
Sounds complicated.
It can be, but we just need to code each condition separately. And then the sequencing of those codes depends on what's being actively treated.
It's like a coding puzzle, figuring out the right order for all those pieces.
Exactly. Now, what about when hypertension starts affecting the brain?
I think that's called hypertensive encephalopathy.
Close. It's called hypertensive cerebrovascular disease. And in those cases, we sequence the code for the cerebrovascular disease first, followed by the hypertension code.
Okay, so the brain takes priority.
It does. And then there's hypertensive retinopathy, which is damage to the blood vessels in the eyes caused by hypertension.
Yeah, those tiny blood vessels are pretty vulnerable to high blood pressure.
They are. And to code that, we use a code from category H35, background retinopathy and retinal vascular changes, along with a code for the type of hypertension.
Okay, so we're connecting the eye problem to the blood pressure.
Right. Now let's talk about resistant hypertension. That's when the blood pressure just won't go down despite medications.
That's a frustrating situation.
It is. And we have a specific code for it, I15.0. But we only use that code when the hypertension is truly resistant, meaning they've tried multiple meds and nothing's working.
So there has to be a documented history of failed treatments.
Exactly. If they're just starting meds or haven't tried a bunch of different options yet, then we wouldn't use the resistant hypertension code.
Makes sense. And now let's move on to atherosclerosis.
Atherosclerosis, that's the buildup of plaque in the arteries.
Which can lead to heart attacks and strokes.
Exactly. And one of the key things to remember about atherosclerosis coding is that we have combination codes for atherosclerosis with angina.
Angina, that's chest pain, right?
Right. And those combination codes make our lives easier because we can use one code to capture both conditions.
So if a patient has both atherosclerosis and angina, we can just use a single code.
Exactly. Like I-25, port 110, atherosclerosis of native coronary artery with angina pectoris.
Now what if a patient has a heart attack?
That's called an acute myocardial infarction, or AMI. And if the patient is admitted for an AMI, then that code comes first, followed by the code for coronary artery disease.
So the heart attack takes priority.
It does. Now, there are different types of heart attacks and different codes to use depending on the type and the timing of the event.
Yeah.
But we can dive into those details another time.
Sounds good. Now, before we move on from Chapter 9, let's talk about strokes.
Okay. Strokes are also known as cerebrovascular accidents, or CVAs. And there are different types of strokes, ischemic hemorrhagic, and even those mini strokes called transient ischemic attacks, or TIAs.
TIAs are scary. They're like a warning sign that a bigger stroke could be on the way.
They can be. But the good news is that they often resolve completely without any lasting damage.
So how do we code those? We
use codes from category I63 for TIAs. And one important thing to remember is that we don't use codes from category I69 sequelae of cerebrovascular disease if the patient doesn't have any lasting neurological deficits.
So if the TIA goes away completely, we don't use those sequela codes.
Exactly. Now, what about those strokes that happen during or after a medical procedure?
Those are scary too.
They are. And we need to code them carefully. The key is to have clear documentation that links the stroke to the procedure. And we also need to specify whether the stroke was an infarction or a hemorrhage.
Okay, so lots of details to capture.
There are. And we can delve into those specifics another time.
Sounds good. I think we've covered the highlights of Chapter 9. Let's move on to Chapter 10, Diseases of the Respiratory System.
Time to take a deep breath and tackle those respiratory codes. This chapter covers a wide range of conditions, from the common cold to pneumonia to asthma.
Okay, let's start with the familiar foe.
Influenza.
The flu, always a seasonal favorite. The key guideline for coding influenza is that it has to be a confirmed case. We can't code suspected or probable influenza, even in the inpatient setting.
So even if a patient has all the classic symptoms, we can't code it unless the doctor specifically says it's confirmed.
Exactly. And confirmation doesn't necessarily mean a positive lab test. It's more about the doctor's clinical judgment. If they document that the diagnosis is confirmed, then we can use the code.
Okay, so we're relying on the doctor's expertise. Now, what if the doctor suspects influenza, but it hasn't been confirmed yet?
Then we would code the symptoms like fever, cough, or sore throat. And we could also use a code from category J11 influenza due to unidentified influenza virus to indicate that influenza is a possibility.
Got it. So we're coding what we know for sure and using those symptom codes when things are still up in the air.
Exactly. Now let's talk about a serious respiratory complication, ventilator-associated pneumonia, or VAP.
VAP, that's a big concern for patients who are on ventilators.
It is. And coding it accurately is essential for tracking these infections and improving patient care.
So what's the key guideline for coding VAP?
We need clear documentation from the doctor that the pneumonia is specifically linked to the ventilator. We can't just assume it's VAP because the patient happens to be on a ventilator and has pneumonia.
So the doctor needs to connect those dots for us.
Exactly. And if VAP is confirmed, then the code is J95.851, ventilator-associated pneumonia.
Okay, so that's our VAP code.
No.
And we would also code the specific organism causing the infection, right?
Absolutely. We need to identify that bacterial culprit.
Now, what if a patient is admitted with a different type of pneumonia and then develops VAP later on?
In that case, the principal diagnosis would be the pneumonia that was present on admission, and then we'd add the VAP code as a secondary diagnosis.
Okay, so we're documenting both the initial pneumonia and the VAP.
Exactly. We're painting a timeline of those respiratory events.
Now I'm ready to tackle Chapter 12, Diseases of the Skin and Subcutaneous Tissue. This chapter seems like it covers a lot of ground.
It does. Everything from acne to skin cancer to pressure ulcers.
Okay, let's start with pressure ulcers. Those are a big deal, especially for patients who are bedridden or have limited mobility.
They are, and coding them accurately is crucial for tracking these wounds and making sure patients are getting the right care.
So what are the key things to remember about pressure ulcer coding?
Well, first of all, we need to know the stage of the ulcer. The stage tells us how deep the wound is and how severe the damage is.
And there are 4 stages, right?
Right. Stage 1 is the least severe and stage 4 is the most severe. And we need clear documentation from the provider to support the stage we're coding.
No guessing allowed.
Exactly. Now, what if we can't determine the stage of the ulcer?
Like if it's covered in dead tissue.
Exactly. If the ulcer is obscured by eschar or slough, then we can't accurately assess the depth. In those cases, we use a code for an unstageable pressure ulcer.
So we're acknowledging that we can't see the bottom of the wound.
Right. And it's important to distinguish unstageable from unspecified. An unspecified pressure ulcer means the stage simply isn't documented.
So unstageable means we can't see the stage, and unspecified means we don't know the stage.
Exactly. Now, what if a pressure ulcer heals during the admission?
Do we still code it?
Yes, we do. We code it based on the stage that was present on admission.
So we're capturing the initial state, even if it improves.
Great. But what if a pressure ulcer gets worse during the admission?
And I'm guessing we code the highest stage documented.
You got it. We want to capture the worst point of the ulcer during that admission.
Okay, that makes sense. Now what about those chronic ulcers that are caused by things other than pressure?
Like diabetic ulcers or venous stasis ulcers.
Exactly. Do those have similar coding guidelines?
They do. We also code those based on their severity, and we use similar guidelines for coding healed ulcers, healing ulcers, and ulcers that get worse during the admission.
Okay, so the same principles apply even though the underlying cause is different.
Exactly. Now, there are a bunch of other skin conditions covered in Chapter 12, but we can save those details for another deep dive.
Sounds good. I think we've got the basics down. Let's move on to Chapter 13, Diseases of the Musculoskeletal System and Connective Tissue.
Chapter 13, this one's all about those bones, joints, and muscles. That's right, like osteoporosis or a tumor. We already talked about those in the context of neoplasms, but they can come from other things too.
So it's not just about the fracture itself. It's about understanding why that bone was so weak to begin with.
Exactly. And when we're coding these fractures, we need to pay close attention to that 7th character. You know, the one that tells us what kind of encounter it is?
Ah, yes, the 7th character. Always adding that extra layer of detail.
Right. So for initial encounters where the patient is getting active treatment for the fracture, we use the 7th character A.
A for active treatment.
Got it. Exactly. And then once that active treatment is done, we switch to D for subsequent encounters.
So we're differentiating between those 2 phases of care.
Right. And just like with other fractures, we have specific seventh characters for those pesky complications like malunion and non-union.
Malunion and non-union, those sound painful.
They can be.
Yeah.
Malunion means the fracture healed, but the bones didn't line up properly. And non-union means the bones didn't join back together at all.
Ouch. So we need those special seventh characters to tell the whole story.
We do. Now, here's a key guideline that connects osteoporosis and fractures. If a patient has osteoporosis and they have a fracture, even if it was just a little fall, we use a code from category M80 osteoporosis to signal that underlying condition.
So we're saying that the osteoporosis played a role even if the trauma seemed minor.
Exactly, because that bone was already weakened, so it doesn't take much to cause a fracture.
Okay, that makes sense.
No.
Now let's move on to a completely different chapter. Chapter 15, Pregnancy, Childbirth, and the Puerperium.
Chapter 15, the land of babies and all things pregnancy-related.
This chapter seems like it has its own set of rules.
It definitely does. It's like its own little coding universe.
Okay, so let's decode that universe. What are the general rules for coding obstetric cases?
Well, the first rule, and this is a big one, is that Chapter 15 codes have top priority. They always come first no matter what other codes are in the mix.
So pregnancy trumps everything else.
Pretty much. We can use codes from other chapters to add more details, but the Chapter 15 code is always the headliner.
Okay, so pregnancy is the main event. Now I'm sure there's an exception to that rule.
There is. If the pregnancy is incidental to the encounter, meaning it's not the reason for the visit and it's not affecting the care being provided, then we use code Z33.1, pregnant state incidental.
So it's like saying, yeah, she's pregnant, but that's not why she's here.
Exactly. But we need clear documentation from the provider to support using that Z33.1 code.
Okay, so no coding assumptions. Now let's talk about those routine prenatal visits. What code do we use for those?
For those nice, uncomplicated checkups, we use a code from category Z34 encounter for supervision of normal pregnancy.
So Z34 is for those everything's going smoothly visits.
Exactly. But what about those high-risk pregnancies?
Yeah, those pregnancies that need extra care and monitoring.
For those, we use codes from category over 09 supervision of high-risk pregnancy, and we can use additional Chapter 15 codes with those over 9 codes to specify any complications.
So we're adding those extra layers of detail to capture the complexity.
Right. Now let's talk about hospital admissions during pregnancy. What if a pregnant patient is admitted but doesn't actually deliver?
I'm guessing the principal diagnosis would be whatever condition led to the admission.
You got it. So if someone is admitted for preeclampsia, then that's the principal diagnosis, even if they haven't given birth yet.
Okay, so we're focusing on the reason for the admission, not the outcome of the pregnancy.
Exactly. Now, what about those cases where a delivery does occur?
Good question. How do we choose the principal diagnosis then?
Well, we usually go back to the reason for the admission. So if someone was admitted for preterm labor and then they deliver the preterm labor code, would still be the primary diagnosis.
Okay, so it's all about connecting the dots between the initial problem and the outcome.
Right. But what if the reason for the admission was something totally unrelated to the pregnancy? Like, let's say someone was admitted for pneumonia, and then they happened to go into labor while they were in the hospital.
So the pregnancy and delivery were completely unplanned.
Exactly. In those cases, the unrelated condition, like the pneumonia, would stay as the principal diagnosis. And then we would code the delivery as an additional diagnosis.
So we're keeping those events separate in the coding.
Right. And of course, we would also code any complications that occurred during the delivery.
Like a tear or postpartum hemorrhage.
Exactly. We want to capture all those important details.
So we're adding layers to the coding to tell the full story.
Now let's talk about those situations where the fetus has a condition that affects the mother's care.
I'm looking at these codes from categories 035 and 036. When do we use those?
We use those codes when the fetus's condition actually changes how we're managing the mother. So if the fetal condition requires extra monitoring, special tests, or even a change in the delivery plan, then we would use a code from 035 or 036.
Okay, so it's not just about noting the fetal condition. It's about documenting how that condition is impacting the care we're providing to the mother.
Exactly. We're looking for that cause and effect relationship.
Got it. So those codes are for when the fetus is driving the care decisions? Now let's talk about sepsis during pregnancy.
Sepsis in pregnancy, that's a serious situation. And the coding guidelines are very specific.
Okay, walk me through those guidelines. What do we need to know?
Well, first of all, we always code the specific infection that's causing the sepsis. So if someone has sepsis due to a UTI, we would code both the sepsis and the UTI.
Okay, so we're identifying both the infection and the source.
Exactly. And if the sepsis is severe, we would add a code for that too, along with codes for any organ damage that's occurring.
So we're capturing that whole cascade of events.
Right. And the same principle applies to sepsis that occurs after delivery puerperal sepsis. We would code the sepsis, the infection, and any organ damage.
Got it. So sepsis coding follows the same rules no matter when it happens.
Now let's talk about another sensitive topic, substance use during pregnancy.
It's a tough one, but it's important to code it accurately so we can understand the scope of the problem and get moms and babies the help they need.
Absolutely. And the guidelines are pretty clear on this one. We start with a code from subcategory 099.3, conditions arising during pregnancy, childbirth, and the puerperium not elsewhere classified. Then we add secondary codes to specify the substance involved.
So like if a mom is using opioids during pregnancy, we would use a code from category F11, opioid-related disorders.
Exactly. And we can use additional codes to capture any withdrawal symptoms or other complications.
So we're painting a detailed picture of that substance use and its impact on the pregnancy.
Right. Now, before we move on from pregnancy, let's clarify a few things about the peripartum period. What exactly does that time frame include?
I'm not totally sure. Can you remind me?
Sure. The peripartum period covers the last month of pregnancy through the first 6 weeks after delivery.
Okay, so it's not just about the delivery itself. It's about that whole transition period.
Exactly. It's a time of major hormonal shifts and physical changes.
Makes sense. Now, what about those long-term consequences that can arise from complications during pregnancy or childbirth?
Ah, yes, the sequelae. We have a special code for that 094 sequelae of complication of pregnancy, childbirth, and the puerperium.
So if someone had a postpartum hemorrhage that led to anemia, and that anemia is still present years later, we would use 094 to connect those dots.
Exactly. We're acknowledging that the past is still impacting the present.
Okay, that makes sense. Now, before we move on to Chapter 16, let's touch on terminations of pregnancy and spontaneous abortions.
Sensitive topics, but important ones. Terminations of pregnancy are coded using codes from Category 004, medical abortion, or Category 007, failed attempted termination of pregnancy. And spontaneous abortions or miscarriages are coded using codes from Category 003, spontaneous abortion.
So different categories for different scenarios.
Right. And one key guideline to remember is that we don't use the code for postpartum hemorrhage for bleeding after an abortion. Instead, we use a specific code for hemorrhage following termination of pregnancy.
Okay, so specific codes for specific situations.
Exactly. Now let's move on to Chapter 16. Certain conditions originating in the perinatal period. First things first, what exactly is the perinatal period?
It's a specific time frame, right?
It is. It starts at 22 completed weeks of gestation and ends at 7 completed days after birth.
So it covers that crucial transition from life inside the womb to life outside the womb.
Exactly. And one of the most important things to remember about Chapter 16 codes is that they're only used on the baby's medical record, never on the mother's record.
So we're keeping those records separate, Chapter 15 for mom, Chapter 16 for baby.
Exactly. Now, what about the principal diagnosis on a newborn's birth record?
Is there a special code for that?
There is. We use a code from Category Z38 live-born infants according to place of birth and type of delivery.
So it tells us where the baby was born and how they were delivered.
Right. And we only use that Z38 code once on the initial birth record.
Okay, so one birth, one Z38 code. Now,
Right.
Can we use codes from other chapters along with those Chapter 16 codes?
Absolutely. We can use codes from other chapters to give more details about the baby's condition. So if a newborn has a heart defect, we would use a code from Chapter 17, congenital malformations, deformations, and chromosomal abnormalities, along with the appropriate Chapter 16 code.
So we're combining those codes to capture both the perinatal aspect and the specific condition.
Exactly. Now, what about those cases where a newborn is being observed for a possible problem, but it turns out to be nothing?
Like a false alarm.
Exactly. That's when we use a code from Category Z05, observation and evaluation of newborns for suspected conditions rolled out.
So it's like a better safe than sorry code.
You got it. But we wouldn't use a Z05 code if the baby is actually showing signs of being sick.
So there has to be a real reason for the observation.
Right. Now let's talk about bacterial sepsis in newborns. That's a very serious condition.
And it can be life-threatening.
Absolutely. And if the documentation doesn't specify whether the sepsis was present at birth or acquired after birth, we code it as congenital.
So we're assuming it's congenital unless the doctor says otherwise.
Right. And we always code the specific organism causing the sepsis, along with any organ dysfunction.
Okay, so we're capturing all those crucial details.
We are. Now let's move on to Chapter 17, congenital malformations, deformations, and chromosomal abnormalities.
This chapter is all about those conditions that are present from birth.
Right. And a key point to remember is that these codes can be used throughout the patient's life.
Even if the condition is diagnosed later on.
Exactly. Like if a child is born with a heart defect, we would continue to use that congenital heart defect code even if they're diagnosed as a teenager.
Makes sense. Now, what about those congenital conditions that have been surgically corrected?
Good question. In those cases, we would use a personal history code to indicate that the condition was present in the past, but is now resolved.
So it's like saying, we fixed it.
Pretty much. Now let's move on to Chapter 18, Symptom Signs and Abnormal Clinical and Laboratory Findings Not Elsewhere Classified.
This chapter is like the catch-all for when we don't have a specific diagnosis.
It is. But one important guideline is that we can't use a Chapter 18 code as the principal diagnosis if we DO have a specific diagnosis.
So we always code to the highest level of specificity.
Right. But if the diagnosis is still uncertain, then those symptom codes are our go-to option.
Okay, so symptom codes are placeholders until we have more information.
Exactly. Now let's talk about comas.
Comas, those are serious.
They are. And the way we code a coma depends on whether we know the underlying cause.
So if the cause is unknown, we would use a code for unspecified coma.
Right. But if we know the cause, like a traumatic brain injury, then we would use a code that reflects the severity of the coma.
And we often use the Glasgow Coma Scale to assess coma severity, right?
We do. And there are specific codes for each level of the GCS.
Okay, so we can use those coma scale codes to provide more detail.
We can. Now let's move on to Chapter 19, Injury Poisoning and Certain Other Consequences of External Causes.
Chapter 19, buckle up.
This chapter covers a wide range of injuries, and it has its own set of coding rules.
Okay, lay it on me. What do I need to know?
Well, one of the key principles is that we need to code each injury separately.
Unless there's a combination code that covers multiple injuries.
Exactly. And when we're coding multiple injuries, we sequence them based on severity. So the most serious injury comes first.
Makes sense. So if someone has a broken leg and a sprained wrist, the broken leg code would come first.
You got it. Now, what about those minor injuries that often go along with more serious injuries?
Like scrapes and bruises.
Right. If a minor injury is at the same site as a more serious injury, we don't code it separately.
So the big injury takes priority.
Exactly. Now, what about those injuries that damage nerves or blood vessels?
Those can be pretty serious.
They can, and we need to code them carefully. If the primary injury is to a nerve or blood vessel, then that code comes first. But if the injury causes a nerve or blood vessel damage, then we code the primary injury first, followed by codes for the nerve and blood vessel damage.
Okay, so it depends on what's the main problem.
Exactly. Now, what about those injuries that happen during a medical procedure?
Like a punctured lung during a biopsy.
Those are considered complications of care. So we would use the appropriate complication codes.
Okay, so different rules for different types of injuries.
Now let's talk about traumatic fractures.
Okay, traumatic fractures, those are the ones that are caused by an external force, right?
Right, like a fall or a car accident. And just like with other injuries, we code each fracture separately unless there's a combination code. And we use those 7th characters to specify the type of encounter.
A for initial encounter, D for subsequent encounter, and so on.
Exactly. Now let's move on to burns and corrosions.
Okay, burns and corrosions, those both involve damage to the skin.
Right. But burns are caused by heat and corrosions are caused by chemicals.
Different causes, similar outcomes.
Exactly. And we classify both burns and corrosions by depth, extent, and causative agent.
Okay, so let's break that down. First, depth. What are the different levels of burn depth?
We have first-degree burns, which are superficial, second-degree burns, which are deeper and involve blistering, and third-degree burns, which are the most severe and involve damage to all layers of the skin.
And each level has its own set of codes.
Right. And when we're coding multiple burns, we sequence them based on severity. So the most severe burn comes first.
Okay, that makes sense.
Yeah.
Now, what about the extent of the burn? How much of the body is affected?
That's where the rule of nines comes in. It's a way of dividing the body into sections that represent 9% each. So the head and neck are 9%, each arm is 9%, and so on.
So it's a quick way to estimate the total body surface area affected.
Exactly. And we use codes from categories T31 and T32 to capture that information.
Now, what about those burns that just won't heal?
Those are tricky. But the rule is that we code them as acute burns even if they've been present for a while.
And if a burn gets infected, we add a code for the infection.
Right. We always capture those complications.
Now, do we use one code for all the burn sites, or do we code each site separately?
We code each site separately. We want to be as specific as possible.
Okay, so we're painting a detailed picture of the burn location.
Exactly. And don't forget to code any sequelae like scars or contractures.
Right, those long-term consequences are important too.
Now let's move on to adverse effects, poisoning, underdosing, and toxic effects.
Oh boy, this sounds like a minefield.
It can be,
Yeah.
but we just need to be careful and follow the guidelines.
Okay, so what are the key things to remember?
Well, first of all, always double-check the tabular list when you're coding these. The table of drugs and chemicals can be helpful, but it's not always enough. You need to go to the tabular list for the final word.
Okay, so the tabular list is our Bible.
Pretty much. And we can use multiple codes to describe the situation. So if someone took multiple drugs, we would code each one separately.
Okay, so we're being specific.
Exactly. Now let's talk about the different types of drug toxicity.
Okay, hit me with it.
So first we have adverse effects. These are those unexpected bad reactions that happen even when a drug is taken correctly.
So it's like a side effect gone wrong.
Exactly. And to code an adverse effect, we first code the reaction itself, like nausea or a rash. Then we add the code for the adverse effect of that specific drug.
So we're linking the reaction to the drug.
Right. Now the next category is poisoning. This is when someone takes a drug in a harmful way.
So like an accidental overdose or taking the wrong medication.
Exactly. And to code poisoning, we use codes from categories T36-T50. And we also need to specify whether it was accidental, intentional, or undetermined.
Okay, so lots of details to capture.
There are. Now, underdosing, that's when someone takes less of a medication than they're supposed to.
Or they stop taking it altogether.
Right. And for underdosing, we use the code for the drug with a special character to indicate underdosing.
Okay, so it's like a modified drug code.
Exactly. Now, the last category is toxic effects. This is when someone is exposed to a harmful substance.
Like chemicals or pollutants.
Right. And to code toxic effects, we use codes from categories T51-T65.
Okay, so different codes for different types of toxicity.
Now, the key to coding all of these is to have good documentation. We need to know what substance was involved, how much was taken, or how much exposure there was, and what the symptoms were.
So it's all about the details.
It is. Now let's move on to Chapter 20, External Causes of Morbidity.
Chapter 20. This is where we get into those external factors that can contribute to injury and illness.
Exactly. Things like accidents, falls, assaults, and even exposure to environmental hazards.
So it's all about the why behind the injury or illness.
Right. And these external cause codes are never the principal diagnosis.
Right.
But they're important because they provide context.
And they help us track trends and identify areas where we can improve safety.
Absolutely. Now, one of the key guidelines for Chapter 20 is that we need to be as specific as possible.
So no vague codes.
Right. We need to capture the cause, the intent, the place of occurrence, the activity, and the patient's status.
Yeah, okay, so lots of details.
There are. And we often need to use multiple codes to fully describe the situation.
Now, what about those long-term consequences of external causes? Like if someone has chronic pain after a car accident.
Those are considered sequelae, and we can code those using a 7th character S.
Okay, so those 7 characters are back.
They are. Now, there's one more category in Chapter 20 that I want to mention. Terrorism-related codes.
Terrorism, that's a heavy topic.
It is, and thankfully it's not something we see very often in coding. But we do have codes for those rare cases.
Okay, so let's just touch on those briefly.
We use a code from category Y38 terrorism to indicate that an injury or illness was caused by a terrorist act. And we also use codes to specify the type of terrorist act and any sequelae.
Got it. So we're capturing all those important details.
Now let's move on to our final chapter. Chapter 21, Factors. Influencing health status and contact with health services.
Chapter 21, the land of Z codes.
Exactly. This chapter is all about those factors that influence a patient's health but aren't actually diseases or injuries.
So like if someone comes in for a vaccination or a checkup.
Right, or if they have a family history of a certain disease, or if they're a carrier of a gene that puts them at risk for a certain condition.
Okay, so lots of different scenarios.
There are. And Z codes can be used as both principal and secondary diagnoses.
So they could be the main reason for the encounter, or they could be an additional piece of information.
Exactly. Now, Chapter 21 is a big one. It covers a lot of ground, so we'll just hit the highlights here.
Sounds good. I'm ready for those Z code highlights.
Okay, so first we have those codes for people who are in contact with or exposed to a disease, but haven't actually developed the disease themselves.
So like if someone was exposed to measles but didn't get sick.
Exactly. Or if someone lives with a person who has tuberculosis.
Okay, so those are exposure codes.
Right. Now, we also have codes for people who have a certain health status, but don't actually have a disease.
Like if someone is a carrier of a gene for cystic fibrosis.
Exactly. Or if someone has a history of a certain disease but is currently healthy.
Okay, so those are status codes.
Right. And then we have codes for people who are seeking healthcare for a specific reason.
Like a vaccination or a screening.
Exactly.
Yeah.
Or if they're coming in for a follow-up after surgery or an illness.
Okay, so those are reason for encounter codes.
You got it. And that's just scratching the surface of Chapter 21. There are so many different Z codes, and they can be used in so many different ways.
Well, I think we've covered a lot of ground today. We've gone through the basic conventions, the general coding guidelines, and the highlights of several key chapters.
We've definitely done a deep dive into ICD-10-CM.
And hopefully our listeners are feeling a little more confident about navigating this complex coding system.
I hope so. But remember, the guidelines are always changing, so it's important to stay up to date.
Absolutely. And if you're ever unsure about a code, don't hesitate to reach out to a coding expert.
Great advice. There's a whole community of coding professionals out there who are happy to help.
Well, that's all the time we have for today. Thanks for joining us for this deep dive into ICD-10-CM.
It was a pleasure being here.
And as always, we encourage our listeners to keep learning and keep coding.